All right, so I think we'll get started. So I'm Arnold Sansevere from Boston Children's Hospital. Thanks everybody for coming this morning. And before I get started, I always like to thank Brad and Candy, because I think this is such a wonderful event for everyone, families, providers. And it's my third year doing this, and I'll keep coming back as long as they ask me. So first things first is this is a very informal session, so at any point if you have a question, just raise your hand. If you guys want to move up, that's okay too. So I like to start off this session by just talking a little bit about what doctors are thinking about when a kid comes in with a questionable seizure, a diagnosis of epilepsy, whatever it may be. Because I think it's really important for families to know what we're thinking about. And then I'm also going to talk a little bit about the process. Once a kid has a seizure, where do we go from there? What tests are important? What are the potential treatment options? And then after that, I'll kind of open it up for questions. But if you don't have any questions, we'll talk about the questions that you should be asking your doctor. And I think that'll be a good way to run the session. We have 50 minutes, so we have enough time. I'll do a little drawing on the whiteboard here, but nothing too crazy. Any questions about the setup or anything like that we're going to talk about? Okay. So the first thing that I always think about when a kid comes in with a first-time seizure is first I want to make sure it was actually a seizure, right? Because there's a lot of mimics out there, and the mimics are specific to certain age groups. Young kids can have things like breath-holding spells. Older kids can have events where they pass out and have syncopal events, and those can look very much like seizures. And believe it or not, in some situations, stress can also cause what looks like a seizure, but may not be the type that we treat with seizure medicines. So that's sort of the first thing. And the way I go about doing that is just by talking to families, right? There are certain things that point you in the direction of a seizure. The biggest thing for me is how kids are responding after the event, right? If a kid has what looks like a seizure and then they bounce back really quickly, that makes me a little bit suspicious. But if a kid has an event and they're really out of it for 20 minutes, 30 minutes, 40 minutes, that makes me a little bit more concerned that it may have been an epileptic seizure. So when a kid comes in with the first time seizure, there's two tests that we rely on. The first test is the EEG. That's the brainwave test. Have you all had experience with EEGs? Okay. How many of you understand what was found on the EEG? Did your doctors talk a little bit about it? Yeah. One of the things about being at Boston Children's is that we get a lot of second opinions, right? Second opinions, third opinions. And I find that oftentimes families are just told that, oh, the EEG is abnormal. And that's how they get to starting a seizure medicine. So I want to talk a little bit about what we look for when we do an EEG. And an EEG is actually a very simple test, believe it or not. I wish it was more complicated than it is, but it's not. So there's 3, maybe 4 things that we're looking for as doctors when we perform an EEG. And the first is just the background brain waves, and they should literally look exactly like this. And like I said, I wish it was more complicated, but it's not. And these brain waves should be at a certain frequency and at a certain height based on a kid's age, right? So if you're a 4-month-old, your waves are going to be taller and a little bit fatter. But if you're a teenager, they'll be shorter and faster. So that's the first thing that we look for. The second thing we look for are any abnormalities that suggest to us that a kid is at risk of having a seizure. Those abnormalities are called spike waves and sharp waves. And they literally look exactly like you would think. Spike wave, sharp wave. And these waves are spikier and sharper than the background brain waves. The third thing we look for is we want to make sure that the brain waves on the right side of the brain look the same on the left. So you can see here that in this case, we find that the waves on the left are a little bit slower than those on the right. So when we see something like this, it just suggests to us that maybe that part of the brain isn't functioning normally. And then the last thing we look for is we look for a seizure, right? And a seizure is just when these spike waves or sharp waves build up over time. And what that looks like is, they start very kind of short, they become very tall, and this is typically what we see when a kid is having the actual seizure itself. So that's just a basic overview to what an EEG is and what we're looking for. One tricky thing is that in some cases, just because a kid has a spike or a sharp wave doesn't necessarily mean that the event that they had was a seizure, if that makes sense. You got to just sort of tease that out sometimes. And then after we do this test, the next test is the brain MRI, right? We want to look at the structure of the brain, because when a kid comes in with a seizure, we want to make sure that the structures look okay and that there's not some abnormality in the brain that would cause this. So once we do all those things and we can say that, this was a seizure, then we decide what we're going to do about it, right? And then the first thing that we always start with is medications, right? Because medications are simple, and there are a couple really good ones out there. When kids don't do well with medications, that's when we start thinking about other options. There was a talk yesterday about diet therapies. One option that we oftentimes talk with families about is the ketogenic diet. And what that is it's a high-fat, high-protein diet. Unfortunately, not too many people know how it works, but it's been around for a really long time, and it can be effective. The challenge is that it's a hard diet to do, right? You can imagine if you're a 4 or 5-year-old, try telling that person that they can't have birthday cake, right? That's challenging. But there are modified forms of the diet, things like the low glycemic index diet, the modified Atkins diet. And then, if kids continue to have seizures and we've tried the diet and we've tried medicines, that is when we talk about more invasive options. And keep in mind, this session is just to give everybody as much information as possible. And the more invasive options range from things like stimulators. Some of you may have heard of the vagal nerve stimulator. That's a device that goes underneath the kind of the armpit here, and it gives a pulse of stimulation to the vagus nerve. It's not painful, and the thought is that suppresses seizure activity. And in some instances, we can go as far as things like epilepsy surgery, where we take out parts of the brain that are abnormal. There's a specific procedure called a corpus callosotomy that actually disconnects their right hemisphere from the left hemisphere, and that helps kids who have types of seizures where they fall to the ground. So those are sort of that's kind of our armamentarium of what we think about if kids are not responding to the first-line medicines. And then I'll talk a little bit about how we go about choosing medicines, and then we'll kind of open it up to questions, and if you guys don't have any, we'll talk about questions you should be asking. So the first step when choosing a medicine is deciding what kind of seizure a kid may have had. And there are two big types. There's generalized seizures, in which you'll see these abnormal brain waves on both sides of the brain at the same time. And then there's focal seizures, where you'll find that these waves are just coming from one side of the brain. And one is not better or worse than the other, they're just a little bit different. If kids have focal seizures, I always start with a medication called trileptal or oxcarbazepine. If they're not focal and they're more generalized, I usually start with a medication called Keppra. Have any of you heard of Keppra before? Yeah, it tends to be the safest medicine. The challenge is that it can come with pretty horrific behavioral side effects in some cases. And I've heard horror stories about Keppra rage, etc. But because it's the safest medicine we have, that's usually the one that we start with. And then there's a lot of other medications out there. Many of you may have heard of Depakote, which is valproic acid. That's been around for a really long time. Yeah, so Depakote's the brand name, valproic acid is the generic name. Another medicine that's out there that I have found to be pretty effective is called clobazam or Onfi. So those are sort of the medicines that I typically start with first, just because I've found them to be the most effective. Unfortunately, they all come with a long laundry list of side effects. For Depakote, it's things like liver dysfunction and pancreatic dysfunction, and I think to myself when I'm talking to families, God, I would never put my kid on this. But at the end of the day, it's tolerated pretty well and it's pretty effective. And then clobazam is also another pretty good medicine, but there are many other seizure medications out there, and oftentimes the choice of a seizure medication has to do with the type of seizure that a kid has, right? So kids with absence seizures, where they stare off into space and their eyelids flicker, those kids can benefit from a medicine called ethosuximide. So you can see there's a lot of different, it's not just like a one-stop shop in a sense. Yeah?
Question about localized seizures. Is it possible to start with a localized seizure and transition into absence?
That's a little bit unusual. I will say that focal seizures can look like an absence seizure, meaning that kids can have eyelid fluttering, they can stare off into space. The difference between that is that typically if it's a focal seizure that looks like an absence seizure, kids are more likely to be tired afterwards. Now some kids can have both, but it's a little unusual for it to start as a focal seizure and then become absence.
What about, we first saw, this is how we found it, she had like a tic.
Yep.
So we don't know if that was a tic or if it was a localized seizure.
Right.
It was very wild.
Yeah, yeah.
And then as soon as she was on the meds, maybe 3 weeks into it, they went away.
Yeah,
It was
yeah.
just the absent seizures.
Yeah.
But would that be a focalized seizure, or would that just be a tic?
So that's not so common. I will say what's common is that kids can have tics and also seizures, but it seems like this is a little bit different. This is almost like maybe it wasn't a tic if it responded to the medication. In that case, my sense is that it may have been more generalized in that instance. That's my take on it from that.
It's considered a generalized seizure?
It is, yep. Yeah, there are three big generalized types of seizures. Absence is one of them. Myoclonic seizures is another one. Myoclonic seizure is where kids have these jerks of their extremities. And then, of course, the larger seizures where kids get stiff and then shake. And the other thing the other thing to keep in mind is that sometimes these focal seizures can start on one side of the brain, but then spread to the other side of the brain, and that's when you get the larger seizure. Yeah.
I have a granddaughter and I watch quite often. She did have a grand mal seizure. She also has cerebral palsy, but it's mild. She used to do a lot of staring, so eyes were not moving, no fluttering or anything like that. But she wasn't really looking at anything, not looking at you. It was like, could that have been? Was it something maybe we missed that could have been
Absence seizure. Yeah, so I will say staring spells are the hardest thing to figure out, without a doubt, especially in that situation. There's a couple ways that I try to figure it out. So one way is exactly what you said. If there's eyelid fluttering and things like that, that's a little bit more clear. The other thing I look for is the muscles in the face, right? So if a kid has an absence seizure, oftentimes those muscles get very weak. That's another way you can sort of tell. The other thing is if they've lost a couple seconds of time. I've had some kids who have told me that, I was at dancing practice and the next thing I knew, my friends were 4 or 5 steps ahead of me and I had no idea, what had happened. Or I had one young girl tell me that she was sitting in a lunchroom having a conversation with her friends, and then suddenly they were on a different topic, and she was like, what happened? Unfortunately, the only way to know for sure with that particular instance is to have an EEG on your granddaughter when it's happening. That said, I find that usually if staring spells are seizures, it becomes extremely clear extremely quickly. So it's unusual to have a couple staring spells and then never see them again. Those are some ways you can sort of tease it out, but like I said, the only way to know for sure is with an EEG, and we worry more about a kid that has cerebral palsy, right? Because that puts you at higher risk for seizures in general. So, yeah. So that's just some very general information about seizures, epilepsy. So at this point, I could start by taking some questions, or as I said, if there are no questions, we can talk about the questions that you should be asking your doctors. And before we do that, can I just get a sense of how many families here are dealing with a new diagnosis of epilepsy? Sort of, yeah. How many of your kids have had seizures for a while? Let's say 6 months to a year. Okay. All right. It just gives me a sense of where we're at. Okay. All right, so I know that's a lot of information, but what questions do you guys have? Yeah, sir.
Why is there such a difference between, say, a child and a teenager with brain waves? And one's like a short.
Yep. It's just the way the brain matures. The mature brain has this rhythm. It's just faster, and it's shorter, and it's just, as I say, the way the brain matures when you're a neonate or a fetus to when you become an adolescent. That's all it is. Yeah. Yeah, of course.
So I guess we missed it. Our daughter had absence seizures for a while. We had the coaches to us after.
Yep.
She had her first tonic clonic. So she was diagnosed with Alzheimer's and tonic clonic. So if we caught it early, could that have prevented the big seizures?
No, and a couple of reasons for that. Kids with absence seizures are always at risk of having the bigger seizures, whether they're treated early or not. Some people say there's up to a 60% risk of having both. The other thing is that the first medicine we start with the staring spells isn't always so good for the larger seizures, but we always start with it because it's the safest. So yeah, unfortunately, I think that would have happened at some point anyway. Yeah. The good thing about absence is that most kids do grow out of it, which is a really good thing. Same thing. It's usually, we say up to 80% of kids with absence will grow out of it. And there's some caveats to that, but. Same. No, it's still the same. Whether you have absences with the big seizures or not, there's still a pretty good chance to grow out of it, which is good.
And then the EEG, if she's not having a seizure when she's being tested, does it just come out?
No, so it can, but it can also just show the spikes. With absence seizures, the spikes tend to come out with things like hyperventilation when they have you blow on the pinwheel. I did forget to mention with the EEG, there's a couple things that we do to try to bring the spikes out. One is hyperventilation, so you'll have to blow on the pinwheel. And the other thing is photic stimulation. They flash the lights at you, and those things can bring out abnormalities in certain types of seizures. Yeah.
That was going to be my question. Why, we've been through, I think, 4 EEGs in 6 months, and why do they, we haven't been told that they've received any information from that. Why do they have to do that every time?
You don't necessarily. It's just a way to sort of really test someone, right? So if you can imagine, and we'll go back to absence because it's one of the easier things to explain. If a kid's doing well on seizure medicines, one way to be sure is to sort of test them, right? And to do that in absence, to really test the brain, is by doing the hyperventilation. When I was a student, some epileptologists used to just use hyperventilation as a way to see how kids were doing. They wouldn't even do an EEG. They would just say, all right, blow on this pinwheel, and if they saw an absent seizure, they would know, all right, well, maybe we need to increase the medicines or think about something else. So, yeah.
So our daughter has the absence. She's having 60 a day on meds for 6 months. And they still do that test. And I guess my question is it bad to be inducing? Because when she has that, we don't see the eye fluttering.
Yeah.
But
Yeah.
we see it on those tests.
Yeah.
Worse.
Honestly, in that situation, I personally wouldn't feel so strongly about continuing to do it.
Is it okay to request that they stop doing those?
Oh, yeah, sure.
Those extra tests?
No, I find that's always okay. But the other thing is, if she's having so many, does it really help to keep doing EEGs? You sort of know. Yeah.
Is it really showing enough that we should be continuing to do that?
Probably not.
Are they seeing enough in those EEGs that they're...
Yeah, it sounds like to me that they're seeing enough, but we all have different styles and approaches, so yeah. So.
For my daughter, once they did the test, it seemed like she just started having a lot more.
Really?
And then I was like, then the first medicine didn't work, but the second one worked, so
Yeah.
it's working, so that's good.
Yeah.
I guess this is kind of a aside. At the beginning, we do a lot of referral. At some point, you move on to another job, get a second, and then
Yeah. So there's no correct answer to that, right? I find that a lot of it has to do with where you are. if you're near to one of these larger epilepsy centers, then the likelihood of coming to Boston Children's, just as an example, and us making a big change is I guess on the lower side of things. I will say that in Boston and other big cities, it's a great resource to have a division of epilepsy, right? And I will say I've been in situations where child neurologists are doing everything they can possibly do to try to help a kid. But this is something we see every day, right? So there have been situations where I feel like I've been able to, make something that for my patient would be very standard, and it's helped a lot. So I would take that into consideration. There's never a downside, I think, if a kid is not doing well with a couple medicines, to just have a second opinion. And I find that most doctors are okay with that. I would be as transparent as possible and say, just talk to your doctor about it. Say, well, what do you think? Do you think that we need to be seen at an epilepsy center to try to figure all this out? Or do you think they might have other things to offer that maybe, we haven't thought about? So that's my typical approach to second opinions. And I found that most doctors are happy, to have our opinion if they're in a situation where they've done everything and their kids aren't responding.
Do you need to see the patient or all the materials that, all the reports and all that stuff?
Ideally, I do like to see the patient, but we do have mechanisms where you can get a second opinion by just sending the records, and you don't have to run up to wherever.
Like you read it all over and
Yeah.
you see something different, you say, okay,
Yep.
then I need to see the patient.
Yeah, exactly.
Just to,
Yep.
fly somewhere to go see.
Yeah, no. We have a couple of mechanisms through our hospital. There's actually a second opinion website if you went to Boston Children's Hospital. And again, most of the big centers have this. But we have capability of doing just kind of like families will send me a list of questions and all the records, and I'll answer the questions. There's another mechanism where you can actually have like a teleconference with me or any of the doctors at our hospital, where you provide us with questions, we look through the records, and then we'll do like a face-to-face over the computer. So those are some options. Some families like that because it's a kind of a pain to get an airplane and go somewhere, go get a hotel, and so that's an option. Yeah, of course. Yeah.
So I have a follow-up question. My niece had a stroke in Europe, so that's where the CP comes from. I think officially it was diagnosed with focal epilepsy, did the EEG, was able to fall asleep, saw the spikes, whatever. His on-cap breath seems controlled, did have absence seizures before. I believe they were absence seizures. Then progressed to the tonic climb. Knowing that she has this issue in her brain, what would be kind of your feedback as far as, that in 2 years, if she's still we'll look at taking her off
Yep.
the medication, knowing, so she's just turned 5, knowing that like puberty's coming up and all of these other stresses on her brain and changes in the brain.
So my typical rule is I always go through the motions of that, meaning that at 2 years I will get another EEG and see if we're still seeing spikes. But in instances where I have found a reason for why a kid has seizures, I am a little bit more hesitant to take them off their medicines. A lot of it has to do with their typical seizures and how families are feeling, how the kid is feeling. Sometimes kids come to me and say, look, I really want to try to get off this medication. And I say, well, the risk is high, but if we can, or maybe not high per se, but I'll usually have the conversation and say, well, if we can accept that, we can try, but keep in mind the chances of them coming back is high. So that's my typical approach. I will.
The larger seizure was in her sleep.
Yeah, so that makes me a little bit more concerned, because of course no one's, many families will sort of watch their kids in sleep, but that's kind of unrealistic. So that would make me a little bit more concerned. So it's sort of like taking all those factors into consideration. So, but I find that it's not like a hard and fast rule with that particular situation. But I always think it's worth at least having the conversation.
I think one parent is holding on to
Yep.
that, and the other parent doesn't want to risk
And that's so common. Yeah.
Just like a little.
Yeah, that is so common where, it's like, and even in situations where I've not found something, reason for it, and I think it's the type of seizure that kids are going to grow out of. It's the same thing, because seizures are so terrifying, right? It's like, if a kid's doing okay with the medicine, why would you want to put yourself through that again? But sometimes in certain instances, I think that it's important to try to get kids off their medicine. But I'm more hesitant in situations where I found a reason for them. So, yep.
And that's kind of why they put her on medication right away, because they knew that there was a reason.
Yep. What else?
So, when my daughter was diagnosed, we had no idea that my mom had seizures. It came out way later.
Yep.
So is that like hereditary or like skips a generation? Because my brother and I are fine.
Yep. So it can be, but so with absence seizures in general, it's such a common disorder, believe it or not, that it's hard to know if it's hereditary or not. If your mom had absence seizures, so that's probably different, probably not related. I did forget to mention. So the other there's sort of three big causes for why kids have seizures. One is a structural abnormality, so there's something wrong with the brain, whether it be a stroke or what we refer to as a cortical dysplasia, where cells don't migrate properly. Those are pretty common causes. Another common cause is genetic, right? But keep in mind that genetic does not necessarily mean inherited, right? That's, I think, a big misconception amongst families, because they come and say, oh my gosh, this is genetic, that means this is my fault or her dad's fault or whatever it is, and that's actually rarely the case. There are some situations in which, unfortunately, that is the case, but it's pretty rare. So those are kind of the bigger reasons. Then there's this subset of seizure disorders that are just childhood seizure disorders, and kids grow out of them. Things like benign Rolandic epilepsy, sometimes childhood absence epilepsy. So I forgot to mention that. That's a good sign. Yeah, that's what I want. When I see someone, I want all the tests to be negative, because those are the kids that have a better chance of growing out of them. Yeah.
So if they do the genetic testing and it comes back positive, that means there's less of a chance that they would grow out of them?
Yeah, that's my typical approach to that, depending on what the positive genetic test is. Because the problem with genetic tests is that oftentimes we find some variant, and we say, well, maybe it's associated with seizures, maybe it's not. And it also it also depends on the type of abnormality that's found on the genetic tests. So,
Is there anything to do for that?
not at this point, unfortunately. There are certain. Well, it just says they're at risk forever. Now, the problem with that is that sometimes, we find a genetic abnormality and we say, well, you have seizures right now, but we don't know what the natural history of that particular genetic abnormality may be. It may be that they grow out of it, but for the time being, we sort of say, all right, look, your risk is higher if we found a reason for why you have seizures. So.
Do you recommend genetic testing? Our insurance doesn't pay for it, but our
Yep.
neurologist said it's time to go.
In situations where kids are failing medicines and I don't have a good reason for it, I will recommend it. The problem, the reason why the insurance companies are not reimbursing is that at this point it's not really changing our management too much, unless you find a genetic test where you know that that the seizures will be made worse by a specific medicine. But that's kind of the exception. Yeah. All right. Any other questions? You can keep asking questions, but I am going to go through a couple things that
I have a
Yeah.
question. So, because ours is young,
Yep.
and she's growing quite, so older son over the last 6 months.
Yep.
Grew quite quickly and gained weight. So my concern was maybe her medicine needed to be adjusted.
Mhm.
So my new daughter-in-law did reach out, and they did increase it because of her body mass had.
Yep.
So that's apparently, I'm thinking something that we're going to have to continue to watch, and if she has growth spurts.
Absolutely.
Sure that-
Yeah, I reevaluate every 6 months, more or less, to make sure that we don't have to do that. But the caveat to that is too, and if you're noticing that your kid is suddenly having a growth spurt, it's always good to just check in and say, yeah, great. So yeah, that's a common thing. I will oftentimes do that just to, because you want the medicine to be in the right range, right? So and for kids, it's based on their weight. So.
Breakthrough seizures I don't want to say wait for, but would prompt you to look at changing meds.
So, the goal is still 0 seizures, right? At some point you have to say, is that realistic? And that takes a little bit of time to figure out. I would say if a kid is still having a seizure a month and we're early, then that's when I'm maximizing the first medicine and I'm thinking about adding a second one until I find the right combination. But once you're starting to think about the third medicine, that's when I start thinking about the other options and start thinking about, what is our baseline seizure frequency here? You have to weigh the risks and benefits of the medicines, right? You don't want 0 seizures but a sedated kid, right?
So first you would look at adding a second as opposed to switching first.
Yeah.
At what point would you think of surgery?
Yeah, so after kids have failed 2 medicines, that's kind of the recommended threshold to say, let's at least do an evaluation for some kind of surgical option. And that's still typically my threshold, meaning that if I've started a second med and I'm thinking about a third med, that's when I say, well, maybe we should just explore our other options. That's my threshold. So once seizures become refractory, and the definition of that is 2 seizure medicines. So.
How young would you consider that?
We've done, I want to say maybe 2 or 3 months. Yeah, it's at that age it's based on weight, but after that it's every kid can have at least an evaluation for it. So.
Maybe because it wasn't, directly, affecting me and my family, But it seems like there's people having less seizures than they used to. Like say in the 80s.
Not sure if it seems the opposite to me, but that's because I have a skewed sample size, I guess, because we're seeing all the refractory kids. So, but
Just wondering,
yeah.
medicines and surgery, or maybe that's the case.
Yeah, I think that more people are apt to do a surgical evaluation these days than they have in the past, but my sense is that it's probably similar to the response rates and things like that are probably still pretty similar. Unfortunately, our new seizure medicines have not been as beneficial as we had hoped, if that makes sense, but yeah. All right. Anything else before we just go into a couple other things? Yeah? Okay, so let's see how we're doing with time here. Sorry. Good. All right, so couple things to ask your doctors that we haven't talked about is what to do if a kid has a seizure, right? I would say that of all the things out there, if you had to know something really well, it's this. So basic seizure first aid is the most important thing. So keep in mind if someone's having a seizure, you want to lower them to the ground, you want them to be away from anything that could be harmful, and you want to turn them on their side because the worry is that if someone aspirates, they can get pneumonia and get very sick. Keep in mind that we no longer worry about swallowing your tongue or many years ago people used to suggest putting a spoon in someone's mouth. Don't do that. And then you sort of have to wait it out, and it's really important to time it if you can. And if you go to the Epilepsy Foundation, they have a lot of really nice resources. One resource that they have is this app that you can pull up. You type in, there's a start and a stop, and it just rings when it's close to the time where you might have to give a seizure rescue medicine. So that's one thing to be sure that you know. Rescue medicines are important. The ones that we use are Diastatic and nasal Midazolam. We've been using more nasal Midazolam lately. We find that it's as effective as Diastat. It's just a nasal medicine. You can imagine if you have a 15-year-old you don't want to necessarily give them a rectal medicine if you can give them a nasal medicine. It's soon to be sort of coming out as an approved rescue treatment. That said, we've been using it in Boston. The challenges that we've had is that some pharmacies are not packaging it up for families. So what that means is that you have to get like a vial of medicine, you got to draw it up yourself. But luckily we have found one pharmacy that delivers it all packaged up. So that's another thing just to be aware of. We typically recommend giving a rescue medicine at around 3 to 5 minutes. The reason for that is that we find that if a seizure is going to last more than 5 minutes, there's a higher chance that it's going to last much longer. Fortunately, short seizures are not thought to cause damage to the brain. Things like absent seizures, if they're quick, we don't worry too much about it. We do worry about the big generalized tonic-clonic seizures. If they last 15 minutes, 30 minutes, an hour, we start worrying more about that. Luckily, despite that, kids still do okay if they have long seizures like that. So those are important things to talk to your doctor about. And then, the other question that comes up that is not easy to answer sometimes, and some families are, I think, afraid to ask the question, is if seizures can be life-threatening. And unfortunately, the answer is yes. It's a rare thing. I'm not sure if you guys have heard of this or not, but there's a lot of discussion in the community about SUDEP, sudden unexpected death with epilepsy. It is something you should talk to your doctors about. And like I said, I even though it's a hard discussion to have, I try to have it just because it's on all your minds. And I think just, some families are just a little hesitant to ask the question. But a lot of resources, again, in the Epilepsy Foundation website about that too. So I would definitely talk to your docs about that. And those are sort of the big questions that families ask me that I think are important for them to know. I'm trying to think if there's anything else. Just don't be afraid to if your doctor says, "Oh, your EEG is abnormal," ask them, "Well, what does that mean?" What do you mean by abnormal? What kind of seizures is my kid having, etc. What are our options moving forward? I think these are all questions that you have the right, or answers to questions that you have the right to know, right? So those are just some things in general. I've gotten a lot of questions lately about monitoring at night, nighttime monitoring. There's a whole slew of seizure watches out there. Keep in mind, we're not yet at the point where we can detect a seizure before it's going to happen. A lot of times it is a peace of mind thing, because a lot of families are just, terrified, right? You don't want your seizure to have a kid in the middle of the night and not know about it. Seizure watches are out there because it detects the motion of the seizure. The problem is false positives, right? So, if a kid turns in an unusual way, it might go off. The other thing I recently learned about it is that apparently for some of these seizure watches, you need like an extra cell phone. You gotta have like a cell phone in the room, in the parents' room. So I didn't know about that. The other issue is that insurance companies aren't really paying for it. So that's something else that comes up. Yes and no. I think they're a little bit different. Question is, if a baby monitor is there, is it going to be enough to wake somebody up? I don't know. I'm not really sure about that. But those are some other questions that families have for me. I don't think if there's anything else. Yeah, I think those are really the big questions that come up. What other? Do you guys have any other questions? I'm happy to answer specific questions or whatever. No.
So the medicine my daughter's on is on is working for the seizures, but her fluids are challenging. Would you recommend staying? Her doctor said just try it for 3 more months.
Yeah, I would give it a little bit of time, but not too much, right? And it depends on, you want to make sure it's behavioral stuff in general is very hard. Because if it's working, then I would be a little, But within reason, right? I mean, like, if your daughter's like throwing chairs at you, you might want to like reassess things. Yeah, but that's my take on that. Yeah.
One of the things with my daughter's medicine, I guess it's also an antidepressant. So I'm wondering how this is going to affect her later.
Yeah.
Even now, it seems like she's a little bit extra energized.
Yeah. Really?
I'm not sure if it's the medicine or if that's just
Yeah.
who she is.
It's hard to know. There are some of the medicines are mood stabilizers. So Lamictal, Depakote, those are medicines that sometimes are used in like psychiatry for mood. But I must say, for the most part, most of these medications are tolerated pretty well. At least the ones that we use. I don't like phenobarbital too much. That's like an older medicine that can cause pretty significant cognitive effects if you're on it for like years and years. Yeah.
If she ever, gets off of it, it's probably, I just wonder if she's going to be like depressed or something.
I don't think she'd be depressed. You might notice a little difference. Maybe she won't be as outgoing, forthcoming, things like that. But yeah.
Are there new meds that are coming out maybe we should be aware of, or how long do you wait before you start
Subscribe.
Before you start prescribing
The new meds?
a new med?
Oh, okay. You mean like a new?
When it's out, yeah.
Oh, yeah.
Available.
Yeah. I wait a little bit, because most of the studies out there the studies that are typically done before there's a new medication on the market are in adults. So I typically wait at least a few months before starting a new medicine. That is not standard. There are some doctors that will prescribe it right away. New medications that are out there, Epidiolex is the big one, right? That's the one that everyone has a lot of questions about these days. Challenge that we're having with it is that it's really it's approved for very specific epilepsy syndromes, which can be a little bit harder. Unfortunately, I've not had a ton of success with it yet, and we'll see. I think that's the newest one out there. Fycompa is new-ish. That's another one that's more for focal seizures. I've prescribed it a couple times in kids. Literally a couple times. I think I have maybe 2 kids that we've tried it on. There's a couple other extended release formulations that are out there. I think Trocandy is one of them. I think that's Topamax. But to say there's like a brand new medicine that's a different mechanism of action or something, I've not heard of any ones as of yet. The biggest one is really the Epidiolex, which is just CBD. So yeah.
You had said, I know 2 people on the Epidiolex really didn't work for them. Is there a reason why it's per se showing that it's not really effective, you're saying?
I'm not sure because the studies that were done for so the initial studies that were done looked at Dravet syndrome, which is a syndrome where kids have seizures that are very heat sensitive. The other was Lennox-Gastaut syndrome, but specifically it was looked at to be somewhat beneficial for head drops. So basically kids like lose all tone and fall to the ground. It wasn't like this huge response to it, but it was something. I think that one of the reasons that we're not seeing it to be as effective as we had hoped is that we are starting to use it outside of those 2 diagnoses, and I just wonder if because it wasn't studied, now we're just sort of finding the result of if it was studied, if that makes sense. But I will say,
You said it's kind of grouped as epilepsy.
right. I will say I've had a couple families, and again, this is not a reason to try it or not try it, say that the seizures didn't get any better, but they were just brighter, and they were sort of a little bit different in a positive way. But again, that's a very low sample size. Just 2 kids that I have that have said that. So yeah.
Is it possible for a kid who has a seizure disorder to lose some of their skills? Like, for example, they were able to do self-care themselves or activity?
Yep. It is possible. I've seen that. A few times. And oftentimes it's in the setting of either a really long seizure or a lot of brief seizures. So, unfortunately that can happen. I've also seen that just in younger kids in just any significant illness per se. So, a kid gets like a pneumonia for a couple of months and families have told me that they lost some skills, but I have seen it with hard to control seizures. So, yeah.
So, as far as if kids get sick, other kids, right, school and whatnot, they don't have the immunity built up yet, especially younger kids. Are there special things to be aware of or watch out for, especially when they're taking oral meds, maybe in the flu and they're having symptoms where they're being
Just to be aware of the fact that, the big triggers for seizures or any illness, you don't necessarily have to have fever and lack of sleep. So if a kid is sick, it's sort of things like making sure that during that time period you're doing the other stuff, right? Like you're getting enough sleep and things like that. I've been in some situations where, if I know this particular trigger is always going to bring out seizures, I'll do things like make a small increase to the medicines during that time, but then go back down. Or, sometimes kids have benefited from a rescue medicine that's, scheduled if we always know that situation is going to bring them out. But again, the caveat is that I always go back down after the illness is over. But yeah.
And is there a common thread of having difficulty falling asleep on something like Keppra?
Keppra, yes. Keppra can do anything as far as I'm concerned. Clobazam, which is Onfi, can either make you tired or can make you a little bit activated. Lamictal tends to be a little activating as well. That's lamotrigine. And again, that's not super common, but I have definitely seen that. Those are the more activating meds that I think that families have told me about.
Is there any food that can trigger a seizure?
Food? No. Not that I'm aware of. Sometimes people think, well, if the high-fat diet suppresses the brain, does that mean the opposite brings out more activity? And unfortunately, that's not the case. So I wouldn't worry too much about that.
I maybe this is what are the side effects?
Mood, like behavioral problems. That's the biggest one. Yeah.
We just noticed sometimes she'll have a day where she's very annoying. So that could be the medication then?
So I think if it's consistent, then
Yeah.
it's possible. For Keppra, if you supplement kids with vitamin B6, sometimes that helps. Not always, but sometimes. Yep.
How much vitamin B6?
I usually do somewhere between 25 to 50 milligrams twice a day. That's like it would be lower for a little baby, obviously, but, yeah.
All I gotta say is thank goodness it tastes okay.
Oh, yeah, right.
Otherwise, we're fighting.
Forget it, I bet. All right, any last questions? Nope. Okay, thanks very much. All right. Thanks, guys.